Many of you are probably familiar in one shape or form with psychological therapy. Maybe you've participated in therapy yourselves before. Maybe your family has gone to therapy. Maybe you have friends and family members who have been in therapy before. And many of you have probably seen therapy portrayed in movies and in TV and in books. During this lecture, I'm going to answer some important questions and address some important issues about psychological therapy. After talking about a few specific examples of some psychological disorders, I'll provide an overview of what psychological therapy is. We'll talk about what important things happen during therapy that lead to improvements for people who struggle with psychological disorders. What important changes occur in therapy sessions? What are some important qualities of effective therapists? In doing so, we'll also watch some videos of some real therapy in action. So to ground our discussion of psychological therapy in a specific context, I want to talk about a few specific psychological disorders. In the previous online lecture, we talked about what psychological disorders are in general, and we define disorders as patterns of behavioral and psychological experiences that violate developmental or sociocultural norms and that produce impairment or interference with life, emotional distress, or increased risk of harm to the self. And I want to talk about two specific patterns of behavioral and psychological experiences that we label as psychological disorders. And then we're going to watch some examples of therapy designed to improve the lives of people who experience those specific problems. But before talking about those specific disorders, I first want to talk about two emotions, how these emotions might function normally, and then how problems might develop related to fear and anxiety. Fear is a present-oriented mood state that involves activation of the body's fight or flight response when triggered by an immediate threat or a perceived immediate threat. I'm sure you've experienced fear at many points in your life and can think of some specific examples, perhaps, of when fear was triggered for you, maybe when an immediate threat was present or an imagined immediate threat was present. Anxiety describes a future-oriented mood state characterized by apprehension and worry, as people focus on the possibility of uncontrollable future danger or misfortune. Both of these emotions, normally, are helpful and adaptive. And indeed, we'd probably be dead if we never experienced fear and anxiety. You can probably think of situations where anxiety has been helpful for you. For example, maybe you have experienced apprehension and worry about an upcoming exam, and that experience of anxiety about that exam motivated you to study. And when you studied more, that lowered your anxiety, helped you prepare for that future potential negative event. An example where anxiety led to helpful and adaptive behavior. Think back to hunting and gathering days. It was probably helpful to experience anxiety about potential future predators eating you, and then to plan for those potential future threats in ways that help to protect you and keep you safe. So I would actually argue that if we think of this evolutionarily speaking, probably early humans who experienced greater levels of fear and anxiety were more likely to survive because they did a really good job of avoiding potentially deadly situations. And indeed then were essentially predisposed to experience fear and anxiety, and maybe even to sort of err on the side of caution and experience slightly too much fear and anxiety, because that's better in terms of survival than experiencing too little fear and anxiety. So fear and anxiety are evolutionary adaptations. They're helpful adaptive emotions, but sometimes people can develop problems with fear and anxiety. Let's look at two specific anxiety disorders and talk a bit about how people might develop problems with these two normally adaptive emotions. So the first anxiety disorder that we'll talk about is panic disorder. You're probably familiar with and have heard of this disorder before. And there are three main characteristics of this problem. The first is recurrent and unexpected panic attacks. Panic attacks are sudden physiological and cognitive and emotional experiences that are time-limited and often experienced as highly negative. They include things like palpitations, or an accelerated heart rate or a pounding heart, sweating, trembling and shaking, sensations of shortness of breath, chest pain or discomfort, feeling nauseous, feeling dizzy, and feeling flushed or excessively warm. Many people experience panic attacks. Think of panic attacks as sort of extreme activation of the fight or flight system. I've had one panic attack as far as I can remember on an airplane. I initially felt sort of nauseous and thought I was having sort of normal motion sickness, but then I began to feel really dizzy. I felt like I was sort of losing control. I was sweating excessively. I was experiencing shortness of breath, and I sort of stumbled to the back of the airplane and was quite nauseous. And I felt out of control of that experience. Eventually, after about 10 minutes, that experience subsided. And that experience with a panic attack is not enough to have problems with panic. Indeed, panic attacks are quite common, and it's within typical normal human experience to have panic attacks, multiple panic attacks even, and even have recurrent and unexpected panic attacks. Panic only becomes problematic, and really what separates experiencing fear and anxiety and panic from struggling with that experience is this second feature of panic disorder. And this is how struggles with panic and fear develop. When people become preoccupied about having future panic attacks, or begin to restrict their life and avoid situations that might elicit future panic attacks. So if I became preoccupied with panic, viewed panic as something that was a problem and as something that I shouldn't experience, and then maybe began avoiding flying for fear of having future panic attacks or being embarrassed in front of people when I might have a panic attack, then my experience with panic becomes problematic because it begins to interfere with my life in some way. It's a barrier for doing what I might want to do, like maybe travel or go to a conference or fly and visit family. So what really separates normal experiences with fear and anxiety and panic from problems is this avoidance of situations that elicit those difficult emotions. We'll explore that theme more in a moment. And then the final feature of panic disorder, and a feature of every disorder, again, is experiencing distress or impairment related to that experience. The other anxiety disorder that we're going to talk about and look at an example of is obsessive compulsive disorder, or OCD for short. And there are three main features of this mental health problem as well. The first is something called obsessions. Obsessions describe persistent, intrusive, and unwanted ideas, thoughts, impulses, or images that elicit emotional distress, such as anxiety. Some common obsessions that people might experience are intrusive thoughts related to contamination or cleanliness, intrusive thoughts related to symmetry, or intrusive thoughts related to harming oneself or others. We all experience odd, intrusive, unwanted, or at times uncomfortable thoughts, ideas, images, or impulses. Some research suggests that up to 100% of participants in research studies report experiencing the occasional intrusive, unwanted thought. that elicits distress. What separates people who experience intrusive thoughts from people who struggle with them really is how people respond to and deal with obsessions. That brings us to the second main feature of OCD, something called compulsions. Compulsions are ritualistic, repetitive behaviors that people perform in response to obsessional thoughts that function to decrease the distress associated with those obsessions. So someone who develops OCD might experience persistent, intrusive, unwanted thoughts about contamination and engage in repetitive, ritualistic cleaning that in the short run reduces the distress associated with those obsessions. So someone might have the thought that maybe they are contaminated with some potential disease, wash their hands in response to that obsession, and do that repeatedly in a ritualistic fashion, to the extent that produces distress or impairment. So let's imagine for a moment that I talked about how I had a panic attack on an airplane. Let's imagine a world where maybe I became very preoccupied with experiencing another panic attack and maybe had a few more panic attacks on some subsequent flights, and then began to avoid airplane travel completely, to the point where that avoidance interfered with my life, and I met criteria then for panic disorder. How might I address that problem? Imagine maybe that I sought out some counseling or therapy. What would a therapist do with me in that situation? What changes might need to occur for me to better manage my experiences with panic? We're going to spend a few minutes talking about those issues as we explore psychological therapy. Psychological therapy refers to the use of psychological methods to cultivate positive behavior change and reduce psychological suffering. We'll talk about what those methods are in a moment, but just know that you've been learning about many of them already. So many of the methods that we use in therapy are derived from clinical and psychological science and are grounded in operant and classical conditioning, for example. You may have heard many other terms referring to therapy, and these terms are relatively interchangeable, things like psychological treatment, psychotherapy, talk therapy, just therapy. All of those terms refer to relatively the same thing. To begin our exploration of what therapy is, we're going to watch a video. And I'd like you to reflect on a few questions as you watch this video, and maybe jot down a few notes. So to give you some context, in this video, the client, on the right-hand side of the screen here, the guy holding the cup there, he's the patient in this therapy encounter, and the psychologist is there on the left. This is Steve Hayes, is the psychologist on the left, a leading clinical researcher and therapist. This is not a real therapy session, but is a recreation of the session. The gentleman on the right is playing the role of a client with OCD, specifically contamination-based OCD. So he experiences obsessions, intrusive thoughts about potential contamination from dirt and other grimy, dirty substances, and then engages in ritualistic, compulsive behavior. He avoids situations where he might come into contact with items that he feels are contaminated, and engages in excessive hand washing and other cleaning rituals in response to those obsessions. And does so to a point that it's severely restricted his life. He doesn't play outside with his kids anymore, stays inside most of the time, and spends several hours a day washing his hands and showering. So we're going to watch a couple minutes and a couple segments from a therapy session with this client. And I'd like you to ask yourself these questions as you watch the video. And again, maybe jot down a few notes. What important things are happening in this therapy session? What is the therapist doing What is the client doing? And importantly, what change is occurring related to the client's cognition and the way maybe that he thinks, the way that he feels, and most importantly, his behavior. What important changes are occurring during this video? Let's watch the video, jot some answers to those questions down, and then we'll talk about it.
It's hardest for me to have this cup in my hand.
Because, go inside it, the cup itself isn't what's hard here.
Because I know you want me to reach in there and touch that disgusting, filthy dirt.
Right, and if you did?
And if I did, it would be on me, and I can't even think of that. If I would have actually touched the stuff and have it on me, and I might get it on you. I might get on these clothes, and I will probably...
I didn't ask you to get it on me, actually. We'll deal with that when we get there. We'll see. So, in other words, what's hard about this is these thoughts. These are thoughts. So we're going to get with the dirt, but I want you also to sort of watch what's going on in your body. What's showing up. And emotions, what's showing up.
Well, physically, I can feel that I'm trying to keep this as far away from my body as possible, from my trunk. The sitting position, if I could push my arms any further away, I would.
Well, then why don't you bring the palm forward? That's it. Okay. We can just use this like a reverse compass. Whose life is this, anyway?
And what else am I doing? I'm trying as hard as I can to not move my fingers.
Okay, so I'd ask you to move your fingers. Good. Good that you noticed that.
All right, I'm going to withdraw my hand a little bit so I can look in this cup.
Okay. Okay. What else is your mind telling you? Especially, I think it's really good to watch for things that it tells you not to do.
Well,
we want to catch these little moves to go away.
It's telling me to not smush it around much because it might grind into me.
Okay, good. So thank your mind for that good advice, and why don't you put it right in there and just squish it around a little bit.
All right. Ugh.
So think back to those questions that I asked before this video. So here is the important changes that I think are occurring here in this therapy session. So first, notice that there was no attempt here to understand why the client felt anxious, to understand where the client's anxiety originated maybe during childhood. One of the biggest misconceptions that people have about therapy is that the goal of therapy is to gain insight or to gain sort of an understanding about why one feels the way they do. That might be an important component of some therapy interaction. And indeed, it might be sort of worthwhile to better understand one's emotional experience. But a misconception that people have about therapy is that somehow insight, or sort of understanding oneself or understanding why people feel the way they feel, actually leads to change and improvement. Decades of research about therapy suggest that insight is neither necessary nor sufficient for effective behavior change to occur. Indeed, what you saw in this video is a picture of modern evidence-based therapy. This is what we call an action-based therapy, because the focus of treatment is on helping people learn new, more helpful ways of behaving. We saw a couple examples of that here in this video. The biggest change we saw was a change in the client's behavior as he moved from avoiding things that elicited emotional distress to actually approaching and contacting those things that elicited emotional distress. And indeed, that change is at the core and the heart of effective therapy. Moving from avoiding situations that elicit distress to contacting those situations, in order to learn how to tolerate those situations and sit with and be okay with feeling extreme emotional distress. And then B, to stop avoiding things that were barriers for living the life that people want to live. So as I mentioned, for this client, his avoidance of stimuli that elicit anxiety are restricting his life. He's spending hours a day cleaning and hand washing. That's not great, because that doesn't lead to some worthwhile, productive, enjoyable life. And he's missing out on hanging out with his kids and doing things that might be meaningful to him. So the biggest change here in this video is this actual change in behavior from avoidance to approaching things that elicit distress. So he's practicing that new behavior here in therapy. And then the second big change is a change in the way that the client relates to his cognitive and emotional experience. One of the things you may have noted while watching this video is that the therapist repeatedly asked the client to say what thoughts he could notice in the moment. And the client, for example, said that he could notice that he was having the thought that he shouldn't stick his fingers into the dirt and move them around. And then the therapist asked him to thank his mind for that thought and go ahead and do that anyway. So there, the client was learning that his thoughts can sometimes be unhelpful and don't necessarily have to control his behavior. And that he can have certain thoughts, but they don't necessarily have to dictate what he does. So he's essentially learning to relate to his internal cognitive and emotional experience in a new way. This is an example of an approach to therapy that we call cognitive behavior therapy, where the focus is on helping people relate to their thoughts and emotions, it's the cognitive piece, in new, more helpful ways, and then to learn new, more helpful, adaptive ways of behaving, the behavior part of therapy. So let's look at another example of a client who struggles with a psychological disorder, and then look at an example of therapy for this client. And this time, we're going to look at a real, actual case example of a real person and her real therapy. So I've written up a case example to describe the struggle that this client, Siddhartha, is experiencing. She's struggling with panic disorder. I'll just quickly read through this in case you're just listening, and then we'll watch the video here of Siddhartha and her therapy. So she's a 35-year-old woman living in Boston. About 3 years ago, she went through a particularly stressful period of life due to long work hours and family conflict. One especially stressful morning, Siddhartha experienced a panic attack while riding the subway on her way to work. When that panic attack occurred, Siddhartha thought she was having a heart attack. Paramedics called and she was taken to a nearby hospital where the emergency room doctor informed her that she experienced a panic attack. A few weeks later, Siddhartha again had a panic attack, this time while riding an elevator at work with some coworkers. She experienced that attack as embarrassing and distressing and feared that her coworkers might view her as weak for having the attack. Over time, her life became more and more restricted. She began riding the bus or driving to work to avoid taking the subway. She also took the stairs instead of the elevator to avoid these situations that might elicit a panic attack. Then she had a panic attack while driving and eventually quit her job and began to avoid all types of transportation in similar situations where she might have an attack and not be able to escape, or where she might feel like she was embarrassed for having an attack. She wants to resume working, resume driving, and resume using public transportation in order to visit her friends around the city and resume work. So here we might identify that the main problem for Siddhartha is not just experiencing panic attacks, but it's avoiding situations that elicit panic. And remember how I talked about the main change that occurs during therapy is learning to approach and contact distress, learning to tolerate it, rather than avoiding situations that elicit it. So let's watch what cognitive behavior therapy would look like for Siddhartha's case. And then we'll briefly summarize this lecture by summarizing what happened for Siddhartha's therapy.
1 week before she begins her treatment, I meet Siddhartha outside the clinic in downtown Boston. With her therapist nearby, we do a brief field test to assess her level of anxiety in situations that have been difficult for her in the past. For starters, I suggest we try to take a subway to a local mall. She says she'll try. When was the last time you were down in a subway like this?
Oh, about 2 years.
Do you feel like you could go through the stalls or not? You just tell me. I mean, I don't want to push you. You just tell me you don't want to do that. Why? What are you feeling?
Because then I feel like the pressure that once I get past the stalls, I've kind of paid for the token and I kind of can't go back. You know, again, it's like that first step that, you know, you're always trying to think of a way out.
Do you want to get out of here?
Yeah, I do. I would know.
A week after we tried to take the subway together, Siddhartha returns to the Center for Anxiety Disorders to begin her therapy. The first 3 sessions focus on panic control treatment to help Siddhartha understand the nature of anxiety and how to deal with the fearful thoughts she often gets during a panic attack.
In some ways, it takes a leap of faith. The patient is so very fearful, and you're having them confront their worst fears.
In some respects, what you're really trying to do here is you're bringing her right to the brink of feeling panic. What if she has a meltdown? What if she has a panic attack right there?
Well, she will likely have a panic attack. But will that mean a meltdown? I don't think so.
Finally, a sort of panic attack chaser. Siddhartha is asked to drink an entire bottle of caffeinated water to actually heighten her anxiety so she can more fully experience the exposure therapy.
We're going to start today. Where do you think we're going to start?
In the elevator.
Yeah. How do you feel about that? What's your anxiety from 0 to 10?
Like 10.
For Siddhartha, like some other agoraphobics, elevators feel like vertical tombs. She hasn't used one in years.
Ready?
She'll take the stairs or nothing at all.
You can do it.
But not today.
Okay. It's okay. Just step in.
As it turns out, getting in is the easy part.
What's your worst fear?
That we'll get stuck
And then what?
and we'll die in here.
Okay.
The therapist is steady and reassuring, but it's still 15 minutes before Siddhartha can even attempt to close the door.
I'm thinking, like, I don't even know if I can do this.
Why can't you? What's holding you back?
I'm afraid. I'm so scared.
It's your fear. This is hard.
Under therapist Sandra Baker's guidance, Siddhartha experiences a full-fledged panic attack.
And I have all these anxious thoughts about what will I do when the door closes.
For Siddhartha, simply being able to ride this elevator will become an act of terror and ultimately liberation.
I'm going to take my hand off of the button, and I want you to feel the anxiety. It will not hurt you. I'm taking my finger off. You're okay. You're okay. You're okay. That's just a behavior. That's anxiety. Feel it. You are fine. Look at how fine.
What are we doing? Oh my God.
Just let it come on.
Oh my God. Okay, I'm gonna let go of you, Sandra.
Finally, Siddhartha breaks through her worst fear.
You're doing it. This is great. You're doing it.
Oh my God.
Okay. Now don't go out of the elevator yet. I want
Okay.
you to just stay.
Eventually, like removing the training wheels, Siddhartha has to do it on her own.
Ready? Okay. You can do this. Oh, this is hard. She's going down.
Repeating the experience again and again breaks the back of her fear, and with each successive trip, Siddhartha's anxiety decreases.
Exactly.
Having taken her first leap of faith and found herself still mentally on solid ground, the next step was slightly easier. Back to the subway, again with therapist in tow. This time, although she was a bit nervous, she was able to take the train with the therapist. Then, once again, she had to do it on her own. Over the next 3 days, Siddhartha would not only ride the subway all over town, but also gain enough confidence to ride a bus by herself for the first time in years, to drive a car again, and to enjoy the simple pleasures of strolling the streets to do a little window shopping.
How are you doing?
I'm fabulous.
By the time I caught up with her at the Prudential Center in downtown Boston, Siddhartha seemed like a very different person from the young woman I'd met just a couple of weeks earlier.
I can just see the way you walk.
I
It
know.
has a little more spring in your step.
Yeah.
Finally, to test the limits of her rediscovered freedom, I asked Siddhartha to join me for an elevator ride to the top of the Hub, a Boston landmark 53 stories up.
Are you ready?
Are you ready?
I am. I really, really am.
I think I'm more nervous than you are at this
Sure
point.
you are.
Whether exposure therapy has a long-term benefit for people who have panic disorder with agoraphobia is still being researched. But for now, for Siddhartha, the sky's the limit.
So we actually do know that now this video is a bit dated. We do know that exposure therapy is quite effective in the long run. So just a few general reflections about the exposure therapy displayed here in this video. The first is, every time I watch this video, I'm always impressed with the courage that Siddhartha displays. Oftentimes, successful beneficial therapy involves incredible courage on the part of clients. As you might imagine, approaching and sitting with situations that elicit emotional distress is not easy and is very challenging. I think it's also important to note that the therapist here, Dr. Baker, displayed a great deal of empathy and positive regard for the client, clearly creating a safe, strong emotional bond between the therapist and the client. And then I'm sure that Siddhartha had agreed to taking these steps. That's another important thing that needs to happen during therapy is therapists and clients having a strong emotional bond, but agreeing with one another about sort of what to do and why to do it during therapy. We call that the therapeutic alliance, bond between the therapist and the client. But again, the main change here for Siddhartha, as with the main change for the client in the previous video, was this actual change in behavior. Therapy itself was active and action-oriented. It didn't involve the client crying and coming to some grand realization about herself and her life. That may or may not happen during therapy. But what was most important is that Siddhartha altered how she related to her experience with panic. Rather than avoiding it, she learned how to approach it, sit with it, and ride that experience out. She may experience future panic attacks again. The goal of therapy is not to eliminate panic, not to eliminate fear, not to eliminate anxiety, but rather to learn to tolerate those experiences as normal parts of life, to develop strategies for working through and managing those experiences. But then most importantly, for actually doing that and approaching situations that elicit, in this case, quite extreme distress. In fact, she brought on a panic attack intentionally. She drank the caffeinated water as a way to increase her heart rate and bring on those physiological sensations of panic. So therapy doesn't actually involve feeling better. For Siddhartha's case, it actually involved, at least in the short run, feeling worse. Therapy involves getting comfortable with discomfort, learning to tolerate and approach those experiences. I hope you learned some interesting things about cognitive behavior therapy and what psychological therapy is and what important changes occur during therapy. If you have any questions, as always, feel free to shoot me an email. I'd be happy to talk to you over email or set up a phone or Zoom office hour appointment. As a reminder, there's an assignment connected with this mini lecture. If you have any questions about that assignment as well, just let me know. Thanks. Have a good day.